Okay, Dr. Bhende.
Hip arthroplasty in intracapsular fracture neck femur. There are three options basically when you talk about elderly patient having a transcervical or intracapsular fracture neck femur. It can be fixed or it can be replaced, and it can be replaced either by hemi or total. So if you see the papers on patients above 60-year-old with displaced fracture neck femur, most of them said that indle fixation does not work very well. And these people where patient are above 80 to 100, these are called super aged patients. Again, the fixation even in the undisplaced fracture doesn't work very well. So all of them have said that arthroplasty has much higher functional outcome and lesser complication rate. Now, if you want to do arthroplasty, question is, do you want to do hemi replacement or a total hip replacement? Now, the benefits of hemi is obviously it's a quicker surgery, lesser morbidity, there is lesser medical complication and much lower risk of dislocation because it's a large bowel arthroplasty and maybe a lesser cost in some cases. Cons is it's a poorer long-term survival, and we are always worried about osteoporotic bone being worn out by your metal head and causing protrusio and subsequent requiring a second surgery and not having a very good functional outcome in this patient. On the other hand, if you do total hip replacement, many papers have mentioned that there is a better functional outcome, there is a longer survival, there is no risk of protrusio acetabuli, but obviously there is maybe higher risk of dislocation, it's a bigger surgery, more bone loss, blood loss, and there may be more soft tissue dissection which is required, maybe slightly increased risk of DVT and medical complication. This is what we feel will happen when a THA. Many articles have been published to compare hip replacement, total hip as well as hemi in these elderly people with transcervical fracture neck, displaced fracture neck femurs, and most of them have come to conclusion that THR has a slightly better function, a lesser morbidity in the long run, longer survival and lesser complication compared to a hemi replacement surgery. Now, this is an interesting paper from Sweden. They have compared 80 plus patients randomized for THR and a bipolar in a displaced fracture neck femur, and a 2-year follow-up they found that there is no higher rate of dislocation in their population of patients in THR, there is no higher post-op morbidity, and there is significantly better improvement in HSS score and functional outcome in the THR group. So they recommend that they should undergo total hip replacement surgery. Now, what is the problem if you want to do THR in a fresh fracture neck femur? Obviously the tissues are very loose and lax. So what happens is, because of lax tissue, there is no capsular fibrosis or thickness which happen in an arthritic hip. So two things can go wrong. There is a high risk of dislocation because hips are loose, and to get the proper balance or proper strength in the hip, we end up putting a longer neck length and we may increase the limb length which is more. So this is a patient TC fracture neck femur operated by a THR, and you can see that there is a slight increase in the limb length in this patient. Many times when you do the operation on this patient, and if you are going to do THR, you can inform that your leg may slightly become longer, that is to maintain the soft tissue balance, and if they are aware about it, they usually do not worry too much about it. But there are ways to reduce the risk of elongation of the risk, and what you can do is, this is a femur being replaced by a standard hip and maintain offset and neck length, so the abductors can become very loose. To prevent that looseness, you, instead of using a long neck, what you can do is, you can use a high offset implant, and that will actually reduce the risk of dislocation. Not only it will reduce increase the soft tissue tension, but every increase in offset will have a increase in impingement free rotation and movement of the hip. So that also reduce the risk of dislocation. Now the other option is, if you don't have high offset, because we don't get everywhere, I mean in Bombay you can get it, but many places you may not get option of high offset implant in all the implant systems. So there is one Indian jugaad we can do. What we do is, we use a long neck length and we try to sink that implant slightly, maybe 3-4 millimeter inside. So that way we can get the higher offset without using a higher offset implant, and this can be possible only if you are doing a cemented hip. But most of the time in neck femur fracture, because the bone is osteoporotic, we usually use cemented, and we don't like to use a non-cemented hip replacement surgery. So another patient, again TC fracture neck femur, here a high offset implant is used, and you can see that offset is increased from 33 to 41, and that has allowed the surgeon to reduce the risk of limb length discrepancy. The other option is we can use a high head size and dual mobility prosthesis, which is easily available these days. So dual mobility, if you want to do THR in the case of fracture neck femur, is a very good option. Now, what are the NICE guidelines? And NICE guidelines are very simple. They have indicated three conditions in a patient. Number one, the patient before the surgery, if he is able to walk independently outdoor with not more than a stick support. Number two, he shouldn't have multiple medical comorbidities which will preclude the use of THR. And number three, he should have at least more than 2 years of expected active life. If the patient fulfills these criteria, NICE guideline indicate that he should do total hip replacement because that will function better in those patients. Now, American Academy adds one more criteria to this, and which is quite important because they have mentioned that you also have to assess the experience of a surgeon, and unless the surgeon is experienced enough, you should not try to do THR. So, in addition to the three patient criteria, the experience of a surgeon is very important if you want to do THR in these patients. Now, so they have recommended that it is better to have between the hemi and total hip is better in this patient. Unipolar and bipolar, it doesn't make a difference. Both of them work same when you want to use hemi. And cemented stem is recommended because with a non-cemented stem, they have found a higher risk of periprosthetic complications like fracture, etc. Now, question is, before I close, how many of you we are using actually these NICE or AOS or some other standardized recommendation? How many of us actually practice evidence-based medicine in India? How many of you do it? Now, don't bother, don't worry. This is an interesting article. They actually try to find out interdepartmental variation in a surgical treatment of a proximal femoral fracture. It is a study in Sweden, and they calculated all the hospitals in Sweden and found out what is the practice. And you can see that at one end, the yellow thing is the hemiarthroplasty, the blue thing is a THR, and the other one faint is internal fixation for a displaced fracture neck femur in elderly people. Now, at one end, some hospitals were using almost about 89 to 90% cases of hemi, while at the same time, same group of fractures, same group of patient, the other end, some of the hospitals using 90% almost THR cases. So, you don't have to worry too much about it. Even in an advanced country like Sweden, where government is regulating everything, they do whatever they want to do. So, basically, if you want to see, you have to think how the patient is, activity of a patient, osteoporosis, functional comorbidities, and your experience. If you think of these three things, then you make a call of whether you want to do a hemi or total hip. And whatever you do, as my previous speaker has mentioned, do it well and patient should be okay. Thank you.